All right, here we go. Hello, everyone, and thank you for watching this webinar on high deductibles, cash plans, and prepays. There's no audio taping or videotaping allowed in any unauthorized reproduction, dispensing, forwarding, or copying this target coding presentation is illegal. A little bit about myself before we get started. My name is Dr. Marty Kotler. I am a chiropractor. I'm also a certified professional compliance officer, certified billing and coding specialist, and I guess I have an unconventional approach to billing and coding compliance because, well, most chiropractors are not certified coders. Most certified coders are not chiropractors. So I take a unique approach to helping chiropractors and their staff members, also acupuncturists and physical therapists, with proper billing, coding, compliance, documentation. I've written many training manuals. I'm a contributing author to many nationwide publications and journals on compliance and coding. I'm a guest speaker at many state association conferences nationwide. So let's start off with a brand new patient. Make sure we have our financial forms in place. There are many forms that the patient should be filling out. You have to choose the ones that are most appropriate for your practice. Obviously, you want a basic new patient health history form that the patient fills out. You want to review all these forms after the patient fills out all these forms. The doctor or staff, you must review all the new patient paperwork. So make sure you have your assignment of benefits form signed, financial policies, informed consent, your HIPAA notice. There's a lot of forms that the patient needs to fill out. So we're going to get the forms out of the way. Now, let's talk about fees. I have a question for you. Is one fee possible? One fee possible across the board for every man, woman, and child that walks into your office? Is it possible? Let's say you wanted to charge $50 across the board for every person that walked into your office. Is that possible? Probably not. Probably not. So let's talk a little bit about fees for a second. There are three factors that usually determine a fee: the work and skills utilized by the provider's overhead administrative costs, the malpractice expense of the provider. So when let's say you're new in practice, or every year you should analyze your fees. How do you know what's an appropriate fee? A lot of ways you can go about this. You could go the scientific route and take a look at the RVUs times the conversion factor for your area. You can buy books. There are many books on fee schedules. You could buy a book that's narrowed down to your zip code to see what fees are most appropriate for your area. So you want to create a fee schedule that's in line with your overall business strategy. Maybe you want to call other chiropractors, call your friends. Maybe you want to be a secret shopper and call around and see what other doctors are charging for your same or similar services in your town. So your fee should be reviewed annually. Sometimes they increase, sometimes they decrease due to competition. So just don't get stuck and use the same fees. I know some docs, they're using their same fees from 1992. So you want to stay updated with your fees. There's a good website called the fairhealthconsumer.org. This is where patients go and see what the fees are for specific codes in your area. And if yours are less than what that website shows, then that makes you look good. So that's a good site. It's called fairhealthconsumer.org. So back to my question, is one fee really possible? Well, probably not. But you need to be profitable. So what good is it if you're in practice and you're not profitable, where you may have to shut your doors? That's not fun. You could be, a really good chiropractor. I actually know some really good chiropractors that I went to school with. They're not in practice anymore. They just couldn't make it in business. They weren't profitable. It wasn't working out. So here's a little exercise. Calculate your monthly overhead by the amount of visits per month, and that's how you'll come up with the amount it costs you to provide a chiropractic treatment. On the screen here, $10,000 is the example here. Let's say that's your overhead and you see about 100 visits a week. So that means it costs you $25 a visit. If you're charging patients $20 a visit, you're losing $5 on each visit. So again, is one fee really possible? Probably not. Let's say, again, you have your normal fee of of $50. Well, if you're involved or in network with a plan, it might be $40. So you have to write off 10. If you're involved with Medicare, the fee might be 35. So then you have to write off $15. You see, if your normal fee is 50 and Medicare pays you 35 and Aetna pays you 45, that does not mean you have a dual fee schedule. We'll get to dual fees in a second. So there are mandated fees, workers' comp fees, personal injury fees, cash fees. So it's okay to have different fees. Doesn't mean you have a dual fee schedule. It's just hard to have one fee across the board. And nowadays you have to educate patients more than ever about fees and medically necessary. You want to keep fees simple. Fee confusion is one of the most common reasons that patients complain to state boards. Patients should be aware of your normal fees if providing discounts, because some providers will give discounts without advising patients of the normal fees. And this can cause unnecessary confusion if a cash patient returns as an insurance patient. I call it sticker shock. So patient education is very important now more than ever. You want to address medically necessary care versus wellness care, because sometimes patients confuse things. They can call, a patient can call their insurance company and say, hey, does my plan cover chiropractic? And they may hear something like this: yes, we cover 25 visits per year as long as it's medically necessary. So now let's talk a little bit about medically necessary versus wellness care. Because sometimes patients come in and go, well, I'm covered for 25 visits, so I'll just come in whenever I want because I'm covered for 25 visits regardless of my clinical situation. Well, that's not the case. I break things down into, a couple of categories here, two categories. You can place your patients into one of these two categories. Every single patient that comes into your office, it's either active care or wellness care. So medically necessary means insurance payable. Wellness care, this is where patient education is important. Patients should understand that when they're in pain and they have restricted motion, they have decreased ADLs, yeah, that's payable by insurance. Now, patients are going to get to the point where they have very little pain, range of motion is pretty good, they could do most of their ADLs. That's when the patient has to understand that's not covered by insurance. That's considered not medically necessary. So you could put your patients into these two categories: active care, which means the patient has insurance and insurance will pay for active care, or you're a cash practice and the patient is coming in with pain and symptoms, they're paying you cash and you're not accepting assignment. And then you have wellness care, which is all cash. Insurance doesn't pay for wellness care. So make sure you understand these two items here will help you make more money and process patients better. Now, deductibles, one of the main issues nowadays. Over the last, I'd say, 6-7 years, deductibles have skyrocketed. Many patients come into your office with deductibles of $3,000, $4,000, $5,000, even $10,000 deductibles. So how do you handle those patients? Well, let's first clarify this. The deductible is the amount that is paid by the patient prior to the insurance company paying. Coinsurance is typically a percentage that a patient is responsible to pay out of pocket. That's usually applies to out-of-network providers. Copays is a flat fee, usually applies to in-network providers. Now, just to clarify before we move ahead here, you're not supposed to waive deductibles. You cannot waive copays. You cannot waive coinsurance. If you're doing prepays, you can't bundle in the copays and deduct a percentage because the patient is prepaying, right? So please understand that. If you have any questions on that, let us know. So again, you cannot waive deductibles. You cannot eat the copay. Can't waive coinsurance. There are situations where you can give patients discounts. Certain patients have financial hardships. But if you're just routinely waiving the coinsurance, the copay deductible, that could be considered a actual false claim. Recently, a chiropractor got fined $80,000 for giving away free electrical stim to Medicare patients. If you want that article, let us know. We'll send it to you. Here's another doctor that he got a letter from Medicare. It says the purpose of this letter is to educate you and inform you that our office received a complaint alleging that you process claims as if the patient is paying their co-payments, but they are not. So that's not a fun letter to get from an insurance company. So let's talk a little bit about high deductibles. This is a challenge. Again, you can't waive them, but you want to tell their patients their financial responsibility. Otherwise, confusion occurs. If you don't tell a patient what their deductible is, and then you just hit them with a bill, that's not fun. The financial report of findings is different if you verify coverage prior, right? If not, the patient usually has no idea how much they'll owe per visit. If done prior, patients could be given options on how to satisfy the deductible. So you could be in-network or out-of-network. It pretty much is the same thing when it comes to deductible. You're going to bill your normal fees. Let's say you bill $50 for a spinal adjustment. Let's say you bill $50 for an extremity adjustment and $50 for therapeutic exercises for a total of $150. The insurance company says, oh, okay, well, you bill this $50 for each of one of those three services, but we only allow $25. So we're going to allow $75 total out of the $150, and that's going towards the deductible. So in that case, you would collect $75 from the patient. But sometimes the patients will say, wait a second, Dr. Kotler, my copay is $75. What's your cash fee? Your cash fee is only $50. Why should I even get my insurance involved, right? So is the patient better off paying your cash fee? You know, you could put patients on payment plans. If you're billing $150 a visit and the insurance company is allowing $75, in my opinion, you could accept the $75. So some patients get a little confused with the deductibles. They're not sure if they have to pay. They don't want to pay it. You say it's one thing. That's oftentimes I hear that you call to verify coverage and they say the deductible is $1,000 on the phone, and then you end up finding out that it was a $5,000 deductible. So what you can do is you could wait for the first EOB to come back if you want to be nice. You could wait for the first EOB to come back and then tell the patient, look, here, you see, I charged this amount. This is what they allowed. This is went towards the deductible, and here's your patient responsibility. So, or the patient could pay something per visit until you figure out what the deductible is going to be. Again, you could put the patient on a payment plan. Some patients just can't afford to get through their deductible. So there's hardship situations, which we're going to get to in a minute. Patients can pay as they go if they want. Some patients will pay you for your services and just give them a walkout receipt. But you want your staff members highly trained on this. This is where some doctors can get frustrated. They look down at their accounts receivable and they go, wow, look how much money is owed to me. But is it a true number? Staff members are not doing their job and getting the over-the-counter collections where it should be. So have staff trainings. Make sure you go through this. You deserve to get paid for everything you do. Why should you write off anything unless it's a mandated situation? But be careful with how you write off certain services. Now, I have a little visual here. Doctors, when you look out into the waiting room, well, at least this is what I did. If I saw 6 patients in the waiting room, I'd say, oh, yeah, there's Mary, she gets headaches, and there's Joe, rotator cuff syndrome, and there's Sally, sciatica, and there's Mr. Jones, he gets neck pain. So that's the way I looked at patients out in the waiting room from a clinical standpoint. Staff members, this is the way you should be looking out in the waiting room. Oh, yeah, Mary, got to get $50 for her for today's visit. Mr. Jones, I need to do a pre-authorization. This patient has a balance of $240. I got to go collect that. This patient, if you're a Medicare provider, got to get the ABN signed today. So staff, you have to be the pit bull. If you can't do it, have somebody else do it. I had one staff member just was not comfortable asking patients for money. That's fine. We'll find something else for that staff member to do. Find the person that's best. Now, doctors, If your staff member is not good at collecting over-the-counter money and looking a patient directly in the eye and asking for the balance due, then doctors, you need to do it. Whoever's the best at it should be doing it. So there are 7 categories I've put together. Again, I like to categorize things. Makes it easier to educate. So there are 7 categories, in my opinion, which will cover every single patient that walks into your office. Cash, which has a couple of subcategories: in-network, out-of-network, Medicare, PI, work comp, DMPOs, and health savings accounts. So cash, let's talk a little bit about cash. Oh, I put together a 30-visit sample plan here. 30 visits, exam, x-rays, 30 adjustments, 30 tractions, a couple of re-exams, total of $2,100 here. So the patient could pay in full on each visit, give the patient a walkout receipt, let them submit it to their insurance. That's pretty straightforward, very simple. Don't use these fees. This is for educational purposes. Okay, so pay per visit. That's pretty straightforward. Now you want to give the patient a discount. I call it a prompt pay discount. That comes right from the federal government. That term, prompt pay discount, there's actually a federal government opinion on prompt pay discounts. They say it's about 20% off your normal fee. So that's fine. Your normal fee is $100. Now a cash patient comes in, you want to give them a discount. Okay, instead of $100, it's $80. Why? If Cigna says, wait a second, you're charging us $100, why are you charging your cash patients $80? Why? Well, you should have a good reason. What's the reason? You don't have to fill out forms. You don't have to wait for payment. You don't have to hire staff to do all the billing. So that's the administrative cost that you're passing on to the patient. 20, 25%. If it's 50, 60, 70, 80%, that's where it could look inappropriate. That's where it could look like a dual fee schedule. Prepays are wonderful. Prepays, well, wait, before we get to prepays, talk a little bit more about prompt pays. So they're designed, when somebody prepays or provides you, I like to call it a prompt pay. You may have heard this term as a time of service discount, right? Time of service discount. I used to call it an administrative fee discount. I've stopped using time of service, administrative discount fee. I call it prompt pay. That's what the OIG opinion calls it, prompt pay. So it's designed to reduce the cost of debt collection. It's not based on the patient's condition, cannot advertise the discount. It's offered only at the financial report of findings. So if anybody's interested in that OIG bulletin on prompt pays, let us know. Now let's talk a little bit about prepays. Prepays are wonderful. Patient pays in advance for multiple visits, less congestion at the front desk, less admin work. Patients rarely miss their appointments, right? That prepay, they understand the value of chiropractic very well. Now, the negatives with prepays are you can't do that if you're in network. You can't have patients prepay their copays or deductibles if you're in network. You don't want to do that up front, especially with Medicare patients. And with prepays, you might have, depending upon your state, you may have to put the money in a separate account and withdraw the funds as the patient is receiving the services. Some states put a cap. For example, there's one state that you cannot collect more than $1,500 in a prepay. So if you're collecting $2,000, $3,000, $4,000 at once, you're violating that particular state's law. So be careful with prepays, but go for it. As long as you're doing it properly, go for it. Next is hardship. Yeah, there are some situations where patients just cannot afford the services. I had one patient came in, she said, Dr. Kotler, I'm a single mom. Things are tough. I just lost my job. I gave it away for free. Wait a second, Dr. Kotler, you gave it away for free? Isn't that illegal? This patient had a financial hardship, had the patient sign the form that they couldn't afford it. I did it very rarely and sparingly, so some patients I gave it away for free. Some patients that had no insurance at all, gave it away for free. Some patients I lowered my fee 20%, 30%. Sometimes I bartered with patients, but it was done very, very rarely. I didn't do something like, okay, all the firemen or the teachers that come into my office, I'm going to waive the deductibles and copay. See, that's not appropriate. So most insurance carriers require healthcare providers to attempt to collect the deductibles and copays. However, there are certain conditions that may permit a healthcare provider to waive partially or in full the deductible. One of them is financial hardship. Here's something right from the federal government. If anybody wants this, let us know. It shows you how to create a sliding scale and give patients a discount. Developing and implementing a discount fee schedule. Let us know if you'd like the full report on this. Next, okay, so now you're in network. Let's continue with that 30-visit care plan. So if you're in network with a plan, you're required to bill. For all services, especially the medically necessary services. You want to check with the plan on what specific forms you may need to fill out, but you're going to collect your copays, your deductibles in full. You're going to bill your normal fees. When you're in network, you must accept assignment. So with that 30-visit care plan, let's say 15 of the 30 visits were medically necessary, so you just want to follow all the in-network rules, and let's say the patient reaches wellness, or they've plateaued, or they've reached maximum therapeutic benefit after the first 15. Remember, we're talking about a 30-visit care plan. Now, in your practice, it could be a 12-visit care plan. It could be a 60-visit care plan. I just chose 30-visit care plan for this particular webinar. So 15 are medically necessary, let's say. So you're going to use all your you're going to bill and use the in-network rules, and then the patient reaches maximum therapeutic benefit, or they plateaued, and now you transfer them for the next 15 visits as cash. That's fine. You could do that. Patient pays for those services out of pocket. Now let's talk a little bit about out-of-network. So out of network, when you're out of network, you want to have the patient sign a form that they understand that you're out of network and the patient is responsible for all the services and the services that are not covered by insurance. You're not going to be billing for those services. So with out of network, again, same 30-visit care plan. You don't have to accept assignment. You could have the patient pay you in full, or you could have the patient pay their co-insurance, right? If you're out of network, it's co-insurance, it's not copay. And you can work out a payment plan with the patients. Make sure the patient signs the form that they understand you're out of network and they're responsible to pay if the insurance doesn't pay. Now let's talk about a little bit about Medicare. First, I have a couple of questions for you regarding Medicare. With Medicare, you're either in or out. You can't be in the middle. You're either in Medicare or you don't see Medicare patients at all. What did I just say? You're either enrolled in the Medicare program or you should not be seeing Medicare patients at all. Let me clarify again, because this is one of the most confusing things when I speak to doctors at seminars, staff, doctors get confused. This is what is incorrect. Well, first, let me ask the question, can you treat Medicare patients without being enrolled in the Medicare program? The answer is no. So here's what I hear. Dr. Kotler, I have Medicare patients come in. I just do exams on my Medicare patients. Do I have to be enrolled? Yes. Dr. Kotler, I have patients come in. I don't bill Medicare. I just have the patients pay me $50. They sign an ABN form. Is that okay? No. You're either enrolled in Medicare, you have an active Medicare number and you're billing Medicare, or stop seeing Medicare patients totally. Don't allow them into your office or get enrolled. Chiropractors cannot opt out of Medicare. So, can you collect cash from Medicare patients without billing Medicare? Yes, you're enrolled, the patient reaches wellness, they check option 2 on the ABN form. That's how you could have a cash Medicare patient. So if you want to do a little bit more research on this, because many times it gets a little confusing. So with Medicare, Cannot opt out, go to the Medicare Benefit Policy Manual to check that out if you want to learn more about that. Actually, if you're not enrolled in Medicare, you're not allowed to use ABN forms. Medicare says if you're out of our plan, if you're not formally enrolled in the Medicare program, you cannot use our forms. So if you're not billing Medicare, you're not enrolled in Medicare, you cannot use an ABN. Don't confuse non-par with opting out. You cannot opt out. You're either par or non-par if you're treating Medicare patients. You're either par or non-par. Non-par is not the same as opting out. So back to Medicare with your 30-visit care plan that we went through earlier. 30-visit care plan with Medicare. So the first 15 visits, we're going with medically necessary care. You're going to bill Medicare. You're going to collect the 20%. If you're par, you'll collect the 20% of the spinal allowed amount. For the exams, x-rays, therapies, collect your full fee. Same thing if you're non-par, collect your full fee for your exams, x-rays, therapies. Now, if you're non-par, you could accept assignment or not accept assignment. Once the patient reaches wellness, if they accept your offer to come in for spinal wellness care, have them sign the ABN form. If they check yes to option 1, then you have to bill Medicare just for denial purposes. Medicare won't pay for wellness care because you're going to remove the AT modifier and replace it with GA. If the patient checks option 2, that's nice, I like that better. Now you have a cash patient. Now let's talk a little bit about personal injury and work comp. So with personal injury and work comp, with this 30-visit care plan, it's a little bit hard to go through that because with work comp in most states, you're not allowed to accept any money from the patient. The PI rules are a little different. In some states, you can have the patient pay you, but if that's the case, most attorneys won't want you to see their patients if you're not accepting assignment. So be careful with the dual fee schedules. I know some docs, they'll bill PI $200 a visit. Patient comes in, cash, do the same thing, and you're charging $50. That is a 75% reduction. That's where an insurance company will go, wait a second, you're billing us $200, your cash patients you're charging $50, why don't you charge us $50? The administrative discount argument doesn't work with that deep of a discount. So try getting your services pre-certified or pre-authorized with workers' comp. Some PI and work comp carriers, they'll bundle your codes, they'll limit your services, they'll limit your fees, require certain forms to be completed every time. So just check with the work comp and PI rules in your state prior to treating patients. Next, DMPOs, Discount Medical Plan Organization. There's a few out there. The one I like best is Cairo Health USA. To me, this is the answer to the dual fee schedule. If you want to bill PI and insurance $200, $300, $400 a visit, and now you want to charge your cash patients $20, you can do that with Cairo Health USA. Patient joins, you join. Beautiful. This is how you can get around that dual fee schedule. Works with cash patients, underinsured, could work with Medicare patients on the non-spinal manipulation services and high deductibles. So I typically recommend put a patient in Cairo Health USA and then do a auto debit each month. Next, health savings accounts. That's fine. Most doctors are not in network with any health savings accounts, so just give the patient a walkout receipt. Try not to even give them codes if possible. Makes it simpler on your end. You could just say, hey, chiropractic exam, 75, chiropractic adjustment, 50, total 125, patient paid, 125, balance 0. Just give them a walkout receipt. If the patient comes back and goes, oh, my human resources director said I need CPT codes. Okay, so there's wellness care with symptoms, and then there's wellness care without symptoms. Well, maybe I should call it maintenance care with symptoms. You see, if a patient comes in and says, I have pain, it's a pain scale of 5. 12 visits later, it's still a 5. 24 visits later, it's still a 5. The patient is not really getting better, but they come in because if they don't come in, they'll go up to a 7 or an 8. So you're maintaining them at a 5. That's typically not covered by insurance. So you want to give the patient walkout receipts with codes. That's fine. If it's a wellness, true wellness, that's S8990. Give that on the walkout receipt, S8990. All right, just a few closing comments here. Now, I like to call it the 35% rule. Do you collect more than 35% of your income from one insurance company? When was the last time you calculated the amount of money you collect from insurance companies you bill the most? $40 per visit is just not enough. So I have a little action plan here, just in case Blue Cross Blue Shield, Aetna, Cigna, Medicare comes knocking on your door. Step 1, get proactive. Step 2, review all new patient paperwork. Make sure the patient signs all the forms, like the review of systems, your health history, assignment of benefits, financial policy, informed consent, your HIPAA notice. Step 4, review the policies from the insurance companies you bill the most on chiropractic and if you do physical modalities and rehab procedures. Step 5, understand the what and the why. Your procedure codes, your CPT codes are the what you're doing, and your ICD-10 codes, your diagnosis codes, are why you're doing them. So make sure they're correct, they can justify medical necessity, or else you'll be given money back. For example, you'll have to give money back if you're billing 97110, therapeutic exercises, and the patient doesn't show any range of motion deficits or decreased strength or decreased flexibility or endurance. Step 6, do a self-test on your notes. Make sure you know what to look for per insurance company. Medicare requires your SOAP notes look different than Cigna. Cigna requires different than Aetna. Aetna is different than United Healthcare, so make sure you know what to look for per insurance company. Step 7, find out what a medically necessary SOAP note looks like and duplicate it. Also, find out what insurance company billing compliance plan looks like and implement it as soon as possible. Audits are increasing. Step 8, put together a simple billing policy manual that explains what you do and why you do it. Example, explain that if you adjust full spine and you're only billing 98940, explain the reason for that, just in case somebody comes knocking on your door. And conduct, step 9, conduct regular staff meetings, specifically with the staff members that do your billing, and especially to the insurance companies that pay you the most money. Do a spot check on your billing company if you use one. Recently, I've seen billing companies reporting fraudulent codes, and the doctor didn't even know until the insurance company came knocking on the door. So just a few closing comments. Please check with all the carriers you bill prior to submitting claims to ensure that it is compliant. Just want to thank everybody for attending. Here's my contact information. Email Dr. Kotler at targetcoding.com, website targetcoding.com, telephone number 1-800-270-7044. Our HIPAA secure fax number is 844-831-2347. We are on all social media platforms. Follow us on Instagram and Twitter. Like us on Facebook. Check out our YouTube channel. Besides these free webinars, we do seminars. We have videos. We do on-site consulting, coaching, membership programs, hourly consulting. We have a forms packet of about, we're up to 75 forms, chiropractic, Medicare, HIPAA forms, HIPAA compliance programs, Medicare compliance programs. We have a guidebook that we sell on the best chiropractic, CPT, and ICD-10 codes to improve reimbursement. This is what it looks like. So again, I want to thank everybody for attending. I hope you learned a lot.